Hi guys. Today we're going to be talking about hoarding disorder and body dysmorphic disorder. I apologize for the change of scenery and that there might be a little bit of background noise in this video. While I was at work, my husband painted the stairs, so I can't get upstairs into the office. Okay, so first we're going to talk about hoarding disorder. So the criteria for diagnosing someone with hoarding disorder is when they experience persistent difficulty getting rid of stuff. When they hold on to things in ways that don't take into account the value of the objects due to a perceived need driven by cognitive distortions that we'll talk about to save these items and distress and anxiety about getting rid of them. Hoarding disorder becomes impairing when it leads to accumulation of possessions that clutter active living areas and basically prevents them from being used for what they're supposed to be used for. The hoarding, either because of the amount of clutter getting in the way or because the clutter actually makes the living environment unsafe, leads to distress and impairment. A lot of the distress and impairment is also social. People with hoarding disorder can become really isolated because they feel like they can't bring other people into their house or let people see how they're living. So the prevalence of hoarding disorder is fairly similar to the prevalence of OCD, about 1.5 to 2.5% of the population. Hoarding, of course, is not inherently disordered. It's a behavior that exists on a spectrum of severity. And about 15% of us engage in hoarding to some degree. On a behavioral level, when hoarding occurs without impairment, so without causing dangerous clutter or without preventing living spaces from being used and without causing shame and embarrassment and isolation, it basically just looks like having more stuff than you need, having a hard time throwing things away, maybe having a lot of collections or having a tendency towards clutter. So in and of itself, hoarding isn't necessarily impairing. So over the next few slides, I'm going to show you a few images from the clutter image reading. This is one of the ways that we diagnose hoarding disorder. We actually show these images. This is a standardized set of images reflecting various degrees of clutter and hoarding. And we ask patients to identify which one their room most resembles. So there's no recognized clear clinical cutoff for what hoarding is on these scales. The clinical cutoff has more to do with the distress and impairment the person is experiencing, how many rooms are cluttered, how much the clutter prevents them from living, and how unsafe their living situation is. But as you can see, it gets bad pretty fast. So this is the clutter image rating scale images for a living room. And right around image 6 here, it starts to look like it would be pretty impossible to use this living room for anything other than a place to store your stuff. This is the clutter image rating scale for the bathroom. I think, oh, yeah, it's not showing the toilet. So by image 4, the tub is not usable. By image 5 or 6, the sink isn't usable. So when we're assessing the severity of hoarding disorder or trying to understand if hoarding behavior meets the clinical criteria for impairment, we assess things like how much of the structure is usable, how many rooms can the person live in, how easy is it to get around the house, are all of the doors and windows accessible, or are there appliances or exits and entrances that can't be used because of the clutter. Sometimes clutter can cause structural damage. So it can, because it prevents things from being accessed, it can lead to maintenance that never gets done, and that causes compounding damage over time. Sometimes the number of items can just become so heavy that it causes structural damage, or it can accumulate water and mold and cause things like rot. Often, even people who don't hoard animals, living in really cluttered situations is unsafe for pets and children. So we also ask, are all the animals and people in the house adequately cared for? And is the house relatively clean and sanitary? So hoarding disorder is the first of the broader obsessive compulsive spectrum disorders that we're going to be talking about, but it really is a distinct disorder from OCD. So most people with hoarding disorder, a majority, don't have OCD. You can see that they're related disorders though, because 20% of people with hoarding disorder do have OCD compared to only about, at most, 2.5% to 3% of the general population with OCD. So someone with hoarding is much more likely than the average person to have OCD. But in the majority of cases, hoarding is totally distinct and not co-occurring with OCD. OCD actually has a better prognosis. It responds better to selective serotonin reuptake inhibitor treatment and to exposure and response prevention. As we'll talk about, the main intervention for hoarding is basically decluttering, essentially exposure to getting rid of stuff, and response prevention, so preventing people from accumulating new stuff. That is much harder when it's applied to dealing with a whole hoarding situation than it is dealing with obsessive compulsive behavior. So compared to OCD, hoarding disorder is more strongly related to attention deficit hyperactivity disorder, which, as we'll talk about in a few slides, makes sense because hoarding disorder involves a lot of executive dysfunction. So even in people with hoarding disorder who don't meet full criteria for ADHD, part of the etiology of hoarding disorder has to do with executive dysfunction. So that helps to account for the overlap. There isn't a real significant overlap between OCD alone and ADHD. That 3% pretty much isn't significantly greater. It's a little bit greater than the population base rate of OCD. So hoarding disorder and OCD do have some overlapping genetic predisposing factors, specifically predisposing factors linked to executive functioning. And of course, there is high comorbidity. So many people with OCD have hoarding behaviors, not full-blown hoarding disorder, but this subclinical behavioral dimension is more common in people with OCD. And of course, again, the prevalence of OCD and hoarding disorder is a lot higher than the prevalence in the general population. So these disorders are related. They share some predisposing factors. They share some cognitive perpetuating factors, but they are distinct. So hoarding disorder is more than OCD, a disorder of executive functioning. Hoarding disorder is related to other disorders of executive functioning, including ADHD, impulse control disorder, which can include things like compulsive shopping, compulsive gambling, compulsive video game use, and substance use disorders. Action monitoring, so this circuit between the prefrontal cortex, the basal ganglia, and communication with the thalamus that is impaired in people with OCD and that causes behaviors to become repetitive. This is one domain of executive functioning, but it's only one. People with hoarding disorder have impairment across the full spectrum of executive functions, including memory, managing their emotions, regulating effort and attention, focusing on things, and getting started with tasks. So activating and organizing tasks. People with hoarding disorder have more of these challenges than people with OCD alone. So this figure is familiar from the OCD lecture. Specifically, the neurobiological vulnerabilities to OCD that we identified have to do with the executive functions around action monitoring, error detection, and response inhibition. Hoarding disorder has, as I said, it shares the action monitoring, response inhibition, error monitoring, executive dysfunction, but it also involves broader executive dysfunction. Precipitation is also different. So both OCD and hoarding disorder can be kind of exacerbated. The underlying vulnerability can be sort of activated or precipitated by life stressors. In the case of hoarding disorder, life stressors essentially overwhelm an individual's somewhat limited executive functioning capabilities, leading them to get overwhelmed and sort of unable to continue to manage their tendency towards acquiring possessions and holding on to things. That tendency is perpetuated by cognitive distortions and compulsive behavior, as we'll talk about later in this lecture. Another precipitant for hoarding disorder is normal aging. So unfortunately, as we get older, our brains do too, and our brains get a little bit less good at most of the functions that they manage, including executive functioning. This is different than dementia. It's normal age-related decline, but that decline in executive functioning for people who are already vulnerable to hoarding disorder, that can also overwhelm their limited executive functions and lead hoarding behavior to get out of hand and turn into hoarding disorder. So unlike most of the disorders that we've talked about in this class, the prevalence of hoarding disorder increases with age. In middle adulthood, the prevalence is at what I said earlier in the lecture, about 2 to 3% of the population. But it jumps up to about 6.5% of the population by middle age and into the elderly years. So part of this has to do with normal age-related declines in executive functioning, as I said. For people who already have some degree of executive functioning limitations, normal declines can put them from the low average range of executive functioning into the below average range, and that can precipitate the development of hoarding disorder. In cases like this, when hoarding behavior is first sort of noted in someone who's elderly, it's really important to rule out early dementia or full-blown dementia. Sometimes dementia can lead to clutter and hoarding behaviors, but if the etiology is fully explained by cognitive decline, it's not really hoarding. It's not hoarding if it doesn't involve the cognitive distortions and the avoidance function of the hoarding behavior. Another factor that could help to explain the relationship between hoarding disorder and age is that the older you get, the more, for most people, for many people, the more housing and financial stability you have. So when you're between the ages of 34 and 54, you might be moving around a lot more. You might have kids living in the house. You might be taking care of your elderly parents. You have less room, less time, less permanence in your life that would allow you to acquire a disabling amount of stuff. And it just takes time to accumulate a true hoard. So someone who's in their 40s can start the process of hoarding, but that hoarding doesn't lead to impairing and distressing clutter for sometimes many years, because it just takes time. So as I said, this increase in prevalence with age is pretty unusual. For most of the disorders that we talked about so far in class, with the exception of schizophrenia, severity tends to decrease with age. And so the prevalence of most mental illnesses in this middle-aged and elderly population is lower than in middle adulthood, and particularly lower than early adulthood. The late teens and 20s is kind of the peak age of prevalence for anxiety, depression, OCD, obsessive compulsive spectrum behaviors, substance use disorder, eating disorder. All of these tend to peak in the 20s and decline with age, and hoarding is an exception to this. So like I said, just having clutter is in hoarding disorder if there aren't these key cognitive distortions perpetuating the hoarding behavior. So some of the most common reasons that people will give you for why they have a hard time throwing things away, number one most common reason is the thought, what if I need it later? Other reasons include kind of identifying objects with memories. So feeling like if you get rid of an object, you're disparaging or potentially risking the positive memories that that item holds for you. Sometimes people with hoarding disorder see their clutter as a collection, and so they have a hard time differentiating between items that are valuable and items that aren't. Sometimes hoarding has sort of superstitious elements to it, almost like a compulsion in OCD. So the thought would be, if I throw this thing out, not for any reason particular to this thing, but just through the act of throwing it out, something bad might happen. And some people who hoard, this is more common in children who hoard, but it can happen across the lifespan, kind of anthropomorphize objects and feel like if they throw things out, it would almost like hurt the object's feelings. So if we break down these sort of stated reasons for hoarding into cognitive distortions, again, the main reason why people have trouble discarding things is a fear that that thing that they throw out might someday be useful or valuable. So, I don't want to throw out this old piece of tinfoil because if I just keep it in this drawer here and then I run out of tinfoil later before I have time to go to the store, it'll be really useful. So I can't throw it away. Along with elevating objects' perceived value and thinking of them as a collection, or giving objects really high sentimental value and sort of imbuing them with the memories that they're associated with. All of these kind of fall into the cluster of risk overestimation or kind of value overestimation. But just having distortions about how important, how useful, how valuable an object really is, leading to a difficulty throwing it away. The other cluster of hoarding cognitions include things like magical beliefs about the object. So this object contains the memories of the time at which I got it, or anthropomorphizing objects, sort of having this sense that objects have feelings. If these are like the only two reasons that someone gives you for hoarding, it might not be hoarding disorder. These types of magical odd beliefs, superstitions, rituals that mitigate anxiety, but that aren't necessarily directly connected to any clear outcome, like the outcome of accidentally throwing away something valuable or accidentally throwing away something that is part of a collection. When beliefs are sort of really odd and not connected to a logical outcome, that starts to sound a little bit more like OCD, or in someone who has no insight that this is unusual, it could be a delusion and a symptom of psychosis. Other types of cognitions that people with hoarding disorder might report is just this general sense that there's too many decisions to make, it's too much work. They feel overwhelmed by the task of organizing and decluttering. This is understandable when you have so much stuff in your house that you can't use your rooms and you have a really hard time distinguishing between valuable and useful and useless objects. That cognitive distortion can lead to these secondary feelings that it's just too much of a task, it's too overwhelming. But when someone is expressing a lot of these feelings, it can be important to rule out things like depression, so just like a lack of energy or motivation to deal with a challenging task. Whether this is really more of like an organizational problem, more driven by true ADHD and executive functioning deficits without this added piece of hoarding disorder cognitions, or whether it's due to cognitive problems, including cognitive decline in older adults. So this is a quick video about the impact that hoarding has on family members and a perspective from a psychologist about how family members can talk to people who hoard and try to help them.
Once you identify this as a problem in a loved one, probably the best approach is to sit down and talk with them about it in as calm and reasonable way as possible. The worst thing you can do is to volunteer to go in and throw things away for them, or to go in and throw things away when they're not around. While doing that, while clearing out someone with a hoarding problem might solve the immediate condition of the home, the problem with the immediate condition of the home, in the long run, these attempts are usually failures, because what happens is in short order, the person fills the home up again. And now there is such a strain in the relationship that they're unlikely to seek help or to seek out their family member for help again. So what we advise is that people sit down with the person and try to come to talk through these issues to help to educate them about hoarding behavior as a problem, and about ways in which they can maybe try to do something to reduce the risk that's associated with this behavior for themselves. Now, ideally, the situation would be to get them into some kind of treatment for hoarding disorder. Oftentimes, people aren't willing to do that. And so the next best thing is to engage them in a conversation so that they recognize this is a difficulty or a challenge, and that they're trying to do something about it. Frequently, what we see is people who hoard recognize this at some level, but they're unable to admit it to their family members because of the relationship that's developed over the clutter with their family member. Oftentimes, people who hoard have spent years doing battle with their family members over their possessions. And so their relationship is colored by these fights they've had. And the person with the hoarding problem tends to be very defensive whenever this issue comes up with a family member. So it's very hard sometimes for family members to be able to communicate with the person with the hoarding problem. So the first thing is to get through that somehow. And the ways that we've seen they're most effective is the person, if the family member pulls back and it's not quite so pushy about throwing things away. In fact, in therapy, when we deal with people with hoarding problems, if our therapists, and we do lots of studies where we supervise therapists, but if any of our therapists, if we find them trying to convince the person to throw something away, then we know they're on the wrong track. Because what we want to do is to get this person into the context where they will be making the arguments for why they should be throwing something away. If someone's trying to convince them to throw something away, then we have a dialogue set up where this helper is trying to convince someone to throw something away, and the person is trying to convince the helper why they should keep the item. And that's not the proper dialogue for any kind of behavior change. The person may agree to throw away a few things here and there just to appease the helper, but in the long run, it's unlikely to have any influence on their behavior. The thing that makes the most difference is when the person decides that they need to do something about it, and they understand enough about the problem. And that's key, I think. Once they understand enough about the problem, they understand that they're going to have to push themselves to challenge their attachments to these possessions to be able to get rid of them. And that's one of the things that we do in therapy. We've also been experimenting lately with self-help groups. And what we're finding is if we can get people on their own to stand up and start challenging their own attachments to these possessions, we do see some positive benefit from it.
Okay, so the key here is that if you're not a cognitive behavioral therapist, it can be very difficult to challenge someone's cognitive distortions around why they keep their possessions. And hoarding disorder is really socially impairing in part because people who hoard often have a lot of negative interactions with their family members about getting rid of things. People in their lives don't understand why they have such a hard time getting rid of possessions and think that the solution is as simple as just throwing stuff away. As was said in the video, that doesn't work because people with hoarding disorder, when they still have these cognitions that make it hard to get rid of things and make them prone to acquiring things because they have risk and value overestimation distortions, they just end up re-hoarding. So even when people are willing to go into treatment and seek help for their hoarding problems, exposure and response prevention and selective serotonin reuptake inhibitors are less effective. Cognitive behavioral therapy, including ERP, for hoarding disorder focuses on psychoeducation about the cognitive distortions and cognitive processes involved in hoarding disorder, helping the patient sort of make a plan and make choices about what to get rid of. And exposure really just looks like exposures to throwing things out. I will say that in my clinical experience, I've worked with children who hoard, and there it's much easier, largely because you're not dealing with as much stuff. Often kids who hoard will have the cognitions that make it hard to throw things away, but because they're kids and their parents have a lot more say in their lives, they actually do end up having to throw things away and part with their possessions more than someone who's an adult, has a whole house that they can fill with stuff and doesn't necessarily have anyone telling them that they have to get rid of their things. So the other disorder that we're going to cover in this lecture is body dysmorphic disorder. So body dysmorphic disorder, like hoarding disorder, is on the obsessive compulsive spectrum, but it's a distinct disorder. BDD involves intense cognitive preoccupation with one or more perceived flaws in physical appearance. These are flaws that are like invisible or seem really, really minor to other people, but to the person with body dysmorphic disorder, because of their cognitive distortions and their attention biases, which we'll talk about later as perpetuating factors, they seem really magnified and really significant. BDD involves some degree of repetitive behaviors related to the appearance concerns that can be kind of conceptualized as compulsion. So usually the function of them is to try to minimize the appearance concern or hide it. BDD is not better explained by concerns with body fat or weight. People with weight and shape-related eating disorders also have really intense body dysmorphia, but their body dysmorphia is focused on body fat, physical shape. People with BDD tend to focus on, as we'll talk about in a few slides, like flaws with their facial appearance for the most part. So on average, patients with BDD spend up to 8 hours a day preoccupied with thinking about their perceived flaws. In our next lecture, we're going to talk about skin picking disorder. Skin picking is really common in people with BDD, but whereas in skin picking disorder, it's driven by sort of sensory urges, almost like a physical feeling. In BDD, the function of skin picking is cosmetic. It's to try to hide or minimize a physical flaw, like pick a blemish off your skin. Even though BDD is meant to be distinct from weight and shape disordered eating, the experience of body dysmorphia is shared between the two. So presumably they share a lot of overlapping risk factors, predisposing factors towards having negative body image and towards being very cognitively and behaviorally focused on perceived flaws. So there's a high overlap with disordered eating. So as I said in the first OCD lecture, some beliefs and behaviors in OCD can seem kind of odd or superstitious. There's a lot of magical thinking. So insight, the extent to which people understand that their thinking is magical or that their thinking isn't totally logical, that their compulsive behaviors aren't necessarily directly tied to real world outcomes, matters a lot in OCD, because when there's really low insight, it can almost cross the line into being delusional. The same is true for body dysmorphic disorder, but the level of impaired insight in the population of people with body dysmorphic disorder is much higher than in people with OCD. Only about 5 to 10% of people with OCD have low or poor insight, compared to 30 to 40% of people with body dysmorphic disorder. And in this population, low insight would look like not even understanding that the physical flaw that they're focused on isn't apparent or seems really minor to other people, but being absolutely convinced that it's way more obvious than it is, and that other people are somehow like lying to them or gaslighting them when they tell them that they don't notice it or don't think it seems important. So these prevalence figures are probably starting to look familiar. The prevalence of body dysmorphic disorder is really similar to the prevalence of hoarding disorder and OCD. And again, these are not overlapping populations. They are overlapping to some extent, but they're not fully overlapping. Hoarding disorder and BDD are totally separate disorders from OCD. The prevalence of body dysmorphic disorder is similar in men and women, and they actually tend to have similar concerns about their appearance. The most common concerns that people with BDD have to do with their skin, so blemishes, flaws, or like differences in skin tone, freckles, their hair, or the shape of their nose. Men with BDD are more likely to be fixated on flaws related to their genitals or flaws related to their musculature. And women are more likely to have comorbid eating disorders. Between men and women, the severity, the level of suicidality, and the prevalence of having cosmetic surgery to try to fix these perceived flaws is pretty similar. So one of the biggest locations to find people with body dysmorphic disorder is in plastic surgery practices. Of patients who are having some kind of cosmetic surgery, whether it's plastic surgery, a dermatological procedure, adult orthodontia, or oral surgery to change like jaw shape, the prevalence of body dysmorphic disorder is much higher than the general population, ranging somewhere from 7 to 16%. The prevalence of body dysmorphia in professional bodybuilders or amateur bodybuilders is also known to be very high. There haven't been good population-wide prevalence estimates, but this is known to be a population that's at very high risk for body dysmorphic disorder. So body dysmorphic disorder is incredibly impairing. The prevalence of suicide attempts and psychiatric hospitalization in this disorder population are higher than any other disorder on the OC spectrum, more equivalent to the prevalence of suicide attempts and hospitalization in people with severe eating disorders. BDD leads to interpersonal psychosocial impairment through things like self-imposed isolation, avoidance of work and social activities, basically hiding yourself because you're so convinced that your flaws are very noticeable to others that it really colors your interactions with other people or makes interactions really distressing and anxiety provoking. People with body dysmorphic disorder are very likely compared to the general population to drop out of school or to leave the workforce. And as many as 10% of people with body dysmorphic disorder are completely housebound. Notably, this 10% prevalence of being housebound in BDD is much higher than the prevalence of being housebound in people with agoraphobia, even though that disorder is more associated with never leaving the house in sort of the popular imagination. Other forms of impairment from BDD come from medical impairment due to having repeated plastic surgeries, engaging in damaging cosmetic procedures like skin whitening or excessive tanning, or abusing steroids, as in bodybuilders. BDD is really highly comorbid with depression, which tends to be secondary to the social isolation, the psychosocial impairment, and the poor body image that's driven by the BDD. And of course, because BDD is on the OC spectrum, it does have overlapping comorbidity with obsessive compulsive disorder, but actually more so with eating disorders. And the body dysmorphia, this fixation on perceived flaws and tendency to overfocus on them, seems to be a shared risk factor. So people with BDD engage in lots of obsessions and compulsions, all focused on monitoring, trying to hide, or trying to avoid people seeing or themselves seeing their perceived flaw. So looking at this table of the type of perceived defects that people with BDD have, the most common, as I said, have to do with the hair, skin, and nose. For the most part, BDD starts on the face or head. So usually the first aspect of someone's physical appearance that they focus on with BDD is something on their face, their hair, their ears. And then the body dysmorphia can actually extend to other areas of the body or to other body parts that are perceived as flawed. The common compulsions that people engage in around these perceived flaws have to do with checking in the mirror to see if the flaw is still there, or to see if it's well concealed, or to essentially just relieve temporarily their anxiety about having that flaw by just seeing it and sort of confirming that it's still there. People spend a lot of time trying to camouflage flaws with makeup or wearing their hair in a certain way, wearing hats, wearing certain clothes, wearing sunglasses. People spend a lot of time on grooming, including grooming behaviors that can be damaging, like skin picking. And then compulsions that are more similar to OCD and other anxiety disorders are things like reassurance seeking from other people. Like, can you see this? How bad is it? Am I ugly? Can other people see it? Is it hidden okay? Mental sort of compulsion, so constantly comparing themselves to other people, either upward comparisons that make them feel worse or downward comparisons in an effort to make them feel better. But in either case, it can be conceptualized as an avoidance behavior because it's avoiding kind of confronting and focusing on, well, I don't want to say focusing because people with BDD really focus on these perceived flaws, but the function of the focus is avoidance. It relieves anxiety. People feel this buildup of anxiety when they aren't seeing, confirming, or thinking about the physical flaw because it's there in the back of their head. So they engage with it, they look at it, they check it, they pick at it, they make mental comparisons to other people as a way of temporarily relieving anxiety about that flaw, similar to how a compulsion temporarily relieves anxiety about an intrusive thought. There's, again, also a ton of avoidance in this population, with such a high percentage being unemployed and even completely housebound. So one of the first-person perspective readings I'm going to ask you to do is from the actor Reed Ewing, who wrote an essay about his experience with body dysmorphic disorder. And two cognitive distortions that he talked about kind of jump out. So one really common behavioral feature of body dysmorphic disorder is this obsessive, compulsive analyzing of the perceived flaws. So he would sit alone in his apartment and take pictures of himself from every angle, seeing these flaws in as much detail as possible. And he had cognitive distortions that you could kind of conceptualize as almost black and white thinking, that because he has this flaw, it means he's ugly, that it's unacceptable to be this ugly, that he's the ugliest person ever. Like many people with BDD, he had plastic surgery while he was still a teenager, including 2 facial plastic surgeries and other cosmetic procedures. And again, like many people with BDD, he discloses a family history of disordered eating and OCD. So a perpetuating factor in BDD is actually this compulsive checking behavior, this visual, behavioral, tactile fixation on the flaw. You would think that if you thought that there was a body part of yours that was hideously ugly and that other people immediately noticed, you might be motivated to avoid looking at it. But like I said, there's this kind of constant push and pull where, because they're so cognitively fixated on it, people with BDD experience temporary relief from the anxiety that they feel about thinking about this flaw by actually looking at it, sort of confirming that it's there, maybe trying to reassure themselves that it's not as bad as they thought or that it's well hidden. But this constant obsessive thinking about the flaw and compulsive checking in on the flaw is the cognitive and behavioral sides of BDD. So what this figure is showing is that compared to healthy control subjects, people with body dysmorphic disorder rate their faces, just seeing a picture of themselves, as extremely aversive. The aversiveness of seeing an unedited picture of their face, that's what this first column is rated as a 6 out of 10. Whereas an average person rates it as like maybe slightly aversive, but hardly aversive at all. You can kind of ignore these other two bars. These are just different like Photoshop manipulations of their faces. This is part of a bigger experiment. The point is that people with BDD find looking at their own appearance very upsetting, yet they do it constantly. So this is an example of that. Compared to both healthy controls and people with social anxiety, who you would think might be kind of similar to people with BDD in that they perceive their social skills as much worse than other people perceive them, and they have a cognitive bias that makes them think that their behavior and their flaws are more noticeable to other people than they really are. Yet, compared to people with social anxiety and healthy controls, people with BDD spend a significantly larger amount of time fixated on their images of their own face, on their perceived flaws, as well as on the same facial feature that they think is flawed in themselves when they're looking at an unfamiliar face. In this study design, all the participants were asked to pick a facial feature of theirs that they considered their worst feature. So compared to healthy controls and people with social anxiety disorder, people with BDD spent more time looking at that so-called worst feature. So looking over here this time, another comparison group that's often used for people with body dysmorphic disorder is people with weight and shape eating disorders, because again, they do have a lot of body dysmorphia. But the body dysmorphia isn't focused on facial features, it tends to be focused on body fat and face or body shape and weight. So people with bulimia nervosa were used as a clinical comparison group here because you would think that they might have some shared risk factors, but other perpetuating factors like attention to perceived physical flaws on the face might help to distinguish these groups. And that's pretty much what was found here. So compared to both healthy controls and people with bulimia nervosa, people with body dysmorphic disorder kind of spent equal amounts of time focused on the feature of their face that they considered to be the least attractive. People with bulimia nervosa and healthy controls actually spent more time looking at the feature of their face that they considered to be more attractive and significantly less time looking at the feature of their face that they considered least attractive. Not that they didn't look at it, they weren't completely avoidant about it, but they seemed to naturally, unintentionally focus on the positive aspects of their face and direct their attention a little bit away from the negative aspects. Both people with bulimia nervosa and healthy controls, as well as people with BDD, actually spend more time looking at the most attractive part of other people's faces. So when they were asked to indicate in this picture of someone, what do you think is the most attractive facial feature? And what is the least attractive facial feature? People with BDD, just like people with bulimia nervosa and healthy controls, were able to identify and spend more time dwelling on the most attractive features of other people's faces. So the difference really is how people with BDD respond to pictures of their own face. They don't have this bias that other people have towards looking at the positive, towards focusing on the more attractive features. But in this study, it was found to be specific to images of their own face. So this figure comes from a facial expression recognition study where people with OCD, people with BDD, and healthy controls were told to basically look at these faces of people making expressions associated with different emotions, so disgust, fear, happiness, a neutral face, sadness, and surprise, and quickly and accurately judge what emotion the person is feeling. So the patients with BDD are here in the left column. Patients with OCD and healthy controls are in the middle and right column, respectively. So what these heat maps are showing is the amount of time people spent looking at each facial feature. The warmer colors indicate more time spent looking. So for the most part, people with OCD and pretty consistently healthy controls have this T-shaped pattern when they're looking at other people's faces. They tend to spend the most time looking at people's eyes, and then secondarily, they spend time looking at people's mouths. Compared to that, patients with BDD, their gaze pattern was kind of all over the place. And the authors of the study kind of accounted for this by saying, given that people with BDD have this bias towards looking at the part of their face that they hate the most, even when they're looking at someone else's face, probably what's happening is that people with BDD are focusing their attention on different parts of the person's face depending on what part of their own face they dislike the most. This tendency causes them to be impaired at emotion recognition because looking at someone's eyes and then looking at their mouth is the most informative gaze pattern for detecting facial expressions of emotion. So the key perpetuating factor in BDD is this behavioral attention bias, this tendency to fixate in looking at their own face, but also to some extent looking at other people's faces on the part of their body that they consider the least attractive for themselves. Probably the tendency to focus on the part of their body that they consider least attractive in themselves when they're looking at other people's faces has to do with this compulsive comparing to other people that people with BDD tend to do. What people with BDD don't show is this seemingly protective, healthy narcissism, where healthy controls and people with bulimia nervosa spend more time looking at the parts of their own faces that they consider to be the most attractive. So essentially, people with BDD are constantly seeking out more evidence to confirm what they already believe, that they're ugly, that this facial feature is so noticeable. And this is just an example of how the cognitive distortions underlying body dysmorphic disorder, this distorted belief that the flaw is much more noticeable than it really is, combined with compulsive behavior, constantly checking, constantly looking, constantly focusing on that feature, leads to this kind of self-fulfilling, self-confirming prophecy where all of their attention is on the worst part of their face, according to them. So it leads them to believe that this is how other people see them too. So treatments for BDD are still kind of in their early stages because BDD is actually also a newer diagnosis. But exposure and response prevention for BDD involves exposure to perceived flaws without engaging in mental compulsions or avoidance. So when people are fixating on the parts of their face that they really hate, they're not just looking at them. They're not just sort of open-mindedly letting themselves see what's there. They're engaging in lots of mental compulsions. They're thinking like, how noticeable is it from this angle? How noticeable is it from this angle? What if I cover it up like this? How much do other people notice this? There's tons of mental compulsions going on while they're engaging in this activity of looking at their face. So in ERP, the goal is to have people look at the perceived flaw and not engage in this mental compulsion, not engage in this self-reassurance seeking, not engage in these sort of subtle efforts to try to hide or minimize or compare to other people. In addition to that, it's also important for people with BDD to practice the act of viewing themselves more holistically. This is important for people with shape and weight eating disorders too. When people with body dysmorphia of any kind look at themselves in the mirror, they have a tendency to zero in on their flaws. But in treatment, they have to learn to zoom out and look at the whole picture, look at their whole body, and balance the part of their body that they see as flawed with attention to every other part of their body. This exercise helps to provide a little bit more evidence about how noticeable that flaw really is. When the flaw is the only thing you look at, it inflates in your mind how noticeable that thing is because it's the only thing you notice. Treatment also involves behavioral experiments, so essentially exposures to going out in public, being around people without doing all of the compulsive things that people with BDD do to cover up their perceived flaws. There's a heavy emphasis on cognitive restructuring. So, restructuring the idea that this flaw is so noticeable to other people, 100 out of 100 people that I pass on the street will notice and stare. If I point out my flaw to someone, it will change the way that they treat me. They'll realize that I'm ugly. All of these things are cognitive distortions that can be challenged. And part of that challenge is gathering evidence through behavioral experiments. With BDD, these beliefs in their own ugliness can be so strong and so fixed that they don't really respond to any evidence to the contrary. And they don't respond to exposure without compulsively checking, compulsively reassuring. So in some cases, the goal of treatment is just acceptance, rather than working with the patient to try to help convince them that they're wrong about how they see themselves, accepting the patient's view of how they see themselves, and then asking, then what? So you're really ugly. So your nose is hideous and everyone notices. How can you still live a good life? How can you still be happy despite how hideously ugly you think you are? In terms of medication, SSRIs work for BDD to some extent, just like they do for other disorders on the OC spectrum. So some takeaways from the OC spectrum so far. OCD involves compulsions that are negatively reinforced, that are repetitive because of deficits in action monitoring, and that are negatively reinforced by anxiety driven by cognitive distortions that that basically magnify the experience of intrusive thoughts because of distortions around perfectionism, the need for certainty, overestimations of how responsible you would be for harm, overestimated likelihood of bad outcomes, and thought fusion, or this belief that thinking something is the same as doing it. Hoarding disorder involves elements of positive and negative reinforcement. So collecting, gathering stuff, looking at your stuff, moving your stuff around. This can actually be really pleasant and positive for some people with hoarding disorder. So this disorder is both positively reinforced and also negatively reinforced because by keeping stuff and not throwing things away, people are avoiding the anxiety and discomfort that comes from having to make a decision about throwing something away. Cognitive distortions underlying hoarding disorder have to do with thought fusion, so imbuing objects with meaning or with real significance, or sort of fusing a physical object with the memories or the time in your life that it represented, and value overestimation or harm overestimation, overestimating the risk involved in throwing away something that might be potentially useful. Compared to OCD, hoarding is related to more widespread executive functioning deficits, whereas OCD involves a specific deficit in action monitoring. Hoarding disorder involves executive functioning deficits in things like working memory, planning, focusing, and executing complicated behaviors. Lastly, body dysmorphic disorder does involve obsessions and compulsions in that it involves constant intrusive obsessive thoughts about their own perceived ugliness, combined with compulsive behaviors like trying to hide, but also constant checking and a very strong attention bias towards those features that are seen as ugly. All right, that is that. Sorry about any background noise on this one. I will see you guys on Friday.